Good morning. Thank you for attending the opening panel discussion on the impact of permanent supportive housing. My name is Rodney Stockment. I'm with the Research and Innovation team at IHCDA. The U.S. Interagency Council on the Homeless made ending chronic homelessness by 2016 one of its strategic goals. Chronic homelessness households comprise a relatively small share of the homeless population, between 18 and 20%, but they consume a disproportionately large number of resources, somewhere between 50 to 60% of the homeless resources. To address chronic homelessness in Indiana, the Indiana Housing Community Development Authority and the Corporation for Supportive Housing launched the Indiana Permanent Supportive Housing Initiative in 2008 with the goal of reducing chronic homelessness and long-term homelessness by developing 1,400 units of permanent supportive housing. We've met our goal. When I started my job in 2006, there was 353 units of supportive housing in the state. Today, there's 1,748 units that are up and operating, and another about 100 or so in the pipeline. To achieve this ambitious goal, IHCDA dedicated unprecedented levels of development capital, rental assistance, and staff time and talent. While chronic homelessness has been reduced by over 34% since 2007, we still want to better understand the efficacy of our strategy so this positive trend can continue. To gain this understanding, IHCDA commissioned the Center for Applied Research at the University of Southern Indiana to evaluate the effectiveness of 5 permanent supportive housing projects developed in Evansville under the initiative. In particular, the evaluation examined how supportive housing affected tenants' housing stability, physical and mental health, use of emergency systems of care, contact with the criminal justice system, and overall quality of life. Just as importantly, the study examined cost savings produced by supportive housing as tenants achieve these outcomes. The study found significant reductions in the use of expensive healthcare systems and criminal justice services. There's also a significant increase in housing stability, allowing tenants to improve their income and improve family relationships. Overall, the study found that supportive housing is the most effective strategy to end homelessness for persons with complex mental health and co-occurring substance histories, offering housing stability and flexible tenant-based services, resulting in significant public cost savings and improved tenant outcomes. Today, we are privileged to have assembled a distinguished panel to discuss the USI study and the effectiveness of the Indiana Permanent Supportive Housing Initiative. It is my honor to briefly introduce our panel. As Senior Policy Advisor at CSH, Peggy Bailey oversees policy efforts to ensure all residents of supportive housing have health insurance, typically Medicaid or Medicare, and access to insurance benefits packages that comprehensively meet their needs. Dr. Marie Peace is Professor of Social Work at the University of Southern Indiana and was the lead researcher in the IPSHI evaluation. Mark McDaniel is the CEO of Great Lakes Capital and has worked tirelessly to attract private equity to supportive housing deals. Jake Sipe needs no introduction, but as Executive Director of IHCDA, Jake has taken our efforts to transition from managing homelessness to ending homelessness to a new level by insisting that we look beyond unit production to start focusing on quality. But before we start our panel discussion, I'd like to share a short video with you. This special video was crafted by Caitlin Evans of Vista working at IHCDA. The video allows voices of 3 tenants at Unity Village in Terre Haute to add a human dimension to the statistics and policy discussion you're about to hear. So without further ado, let's start by hearing their voices. If we could please start the video.
5 years and I got a divorce and different things happened. And then I was diagnosed with bipolar, manic depressant, and post-traumatic stress disorder. And I wound up on the street, and I went into the hospital because of my blood pressure. And while I was in there, they asked me about this place, if I wanted to have an apartment here. And so I waited. They put me in a group home for a week or two, and then I got my apartment here, and it's been the biggest blessing that I could have in my life. I got my Social Security disability, which made me be able to pay my rent, and I got all my medication. I have a nurse that fixes it up for me.
I was always worrying, anxiety was always up. And here I have hobbies that keep me busy. When I moved here, I was able to get Medicaid, and that helped me out quite a bit with getting my prescriptions and keeping them filled. You know, having responsibility again, I was a little nervous, but they made it real easy for me. You know, introduced me to everybody here. I started going to groups pretty quick.
Right.
And at the homeless shelter I stayed in, I mean, you had to constantly watch your stuff. Someone was always trying to steal what you had, and so I can relax here.
Well, basically I was living between my two sisters. One in Indianapolis, one here in Terre Haute, and it just wasn't working out. I have my medical now, so
That's great.
That's a miracle, because a lot of the medication that I take costs a lot of money.
Yeah.
And there's no way I'm going to be able to pay for it because I have no income. I had issues with my sister because I had to live with them.
Yeah.
And now we're like sisters should be. I've been happier here because of the people that are around. So this is, bringing out a different side of me. Because now I know that I have control over what I do. I don't have to worry about somebody telling me what to do. I can do it on my own. And if I need help, I know I can go to the staff or somebody, to get help.
Hello, and good morning, everyone. As Rodney said, my name is Peggy Bailey, and I am with the Corporation for Supportive Housing. I am our national staff. I'm located in our Washington, D.C. office, and I work with Lori and other CSHers across the country to help create more supportive housing, and not only working on the housing piece, but also making sure that the services and supports are there for the people that need them. You know, until recently, most of the prominent evaluations of supportive housing were done in New York or San Francisco or Chicago. And to be honest, I was getting really tired of having to have people from San Francisco and Chicago and New York on all the panels that I was putting together at national conferences. There was a time where I banned myself from having anyone from New York on any panel because it was ridiculous. You know, the resources that New York City and New York State have are more than most states have. And so sometimes we think the things that they're doing aren't replicable in other parts of the country. But that's what's great about the study that we're going to talk about on this panel, is that it's looking at Evansville, Indiana. That's a place that's like almost everywhere else, you know, with systems that can create systems and supports and has limited resources to make, but is working to make real change for people in the community. and that's and not only will what we are seeing in Evansville help supportive housing and help make the case for that, but it'll also help make the case for affordable housing broadly. At CSH recently, we analyzed the projects that we've lent money to across the country and found out that for every 1 unit of supportive housing, we were creating 4 units of affordable housing. States and communities are prioritizing supportive housing, but it's important to have integrated communities and building units where some units are carved out for supportive housing and others are affordable housing, or making sure that where we build a supportive housing project, we're also building other affordable options in the community. So because communities are prioritizing supportive housing, and we can make the case for why that is working for other systems, it also brings the entire affordable housing community along with it. But more often than not, right now what we're doing is using existing resources and reprioritizing those. To get new money to the table, we're going to have to engage other systems, like the healthcare system and the corrections system, who can be influential and help us make the case for why we need more affordable housing units. But to do that, we have to show that we're achieving their goals. And that is what I want you to get out of today's panel. What are the messages that we can use to build the number of voices that are helping us, whether it's in the State House or in Washington, D.C., to create more units of supportive housing, both capital and rental assistance? The study, for example, you'll hear about the corrections side and the way that that can help us create more supportive housing. We've been working on at CSH for a while now around our reentry initiatives. We all know that our jails and prisons are becoming housers for people with behavioral health, particularly mental illness, across the country. In Denver, the city realized that in a few years they were going to get to a tipping point where they were going to have to build another jail. But instead of doing that, they said, wait a second, let's invest in housing. Let's figure out how we can create better housing options for the people that are in our jails, because we know if we do that, they'll connect to services and we won't have to spend millions of dollars on a new jail or prison. So CSH is involved there in a social impact bond initiative, or a pay for success model, where we're bringing investors to the table from the private community using tax credits from the state and service providers that are already in Denver to create housing options for people exiting out of jails and prisons. The work from that will be able to show why affordable housing is actually the answer and not another jail. Also, my work at CSH is mostly on the healthcare side, and one of the things that we've been doing lately is working with managed care organizations. Our first meeting with them was interesting. We were talking about ending chronic homelessness, and where we've come from the supportive housing industry. We usually were talking about creating, hundreds, maybe a few thousands of units to end chronic homelessness. But when we engage the managed care organizations, and they're talking about moving people out of nursing homes and ending emergency room use and keeping people out of inpatient stays in the hospital, just in one state alone, and talking about moving people out of nursing homes, That's tens of thousands of units of affordable housing and supportive housing that are needed for that population. So it takes it to a whole new game, a whole new scale. And while it's very daunting, the corrections and health being able to show the size and the scale of the need beyond ending homelessness is going to be effective in the future in helping us create more supportive housing. So how do we do that? How do we take these messages? There are things that I've found across the country that are important to share. There are three big things. The first one is first we have to explain what supportive housing is. That may seem obvious. A lot of us have been talking about supportive housing for a long time. But because it comes out of the homelessness and as a homelessness intervention, and for so long we've talked about housing stability of supportive housing and more than we've talked about the other outcomes, healthcare and correction systems may not know what we're talking about when we say housing first or harm reduction strategies or patient-centered care. So we have to explain that supportive housing does all of those things. We also have to talk about who supportive housing is for. That is not, for us, it's about ending homelessness or at least providing housing stability. But for the healthcare system, it's about reducing diabetes, being able to take your medications, accessing medical care, those sorts of goals that are important to the healthcare system. And then they have to have the confidence that that we can help them achieve those goals. And the way that the healthcare system talks about those goals in particular is around the triple aim, that we have to show that we can reduce costs, increase care, and improve care, and increase access. And that's where studies like the supportive housing study that's looking at Evansville is so important. It illustrates similar findings to what we see in the big cities like New York and San Francisco, and goes another step further by interviewing tenants and asking them how they feel. What are their utilization habits, and what's the overall impact of the community? So we're starting to do more to look at, okay, we care about housing affordability and stability, but what are the things that we're solving for other systems so that we can make the case for more affordable housing? This is an area where we've fallen short in the supportive housing community in the past, and we're trying to do a better job. And this is where health system payers, managed care, state Medicaid agencies, and Medicare are shifting how providers get paid. You know, right now, they're often getting paid for utilization. So if we go to a hospital and we say, okay, well, we're going to reduce your inpatient stays, the first thing they see here is, oh, you're going to reduce my revenue. But as the health system payers, like I said, Medicaid, health insurance programs shift from paying for utilization to paying for outcomes, that's when they're going to need us. And that's what we're seeing around the country. As systems make that shift, they're saying we need to pay for these things that we call the social determinants of health. And housing is one of the number one social determinants of health. So the more that we can do studies and show and talk about ourselves in a healthcare or corrections, as I said, context, the better, the more champions we'll have for creating more units. And a signal that this is happening is that the federal agency that oversees Medicare and Medicaid, the Centers for Medicare and Medicaid Services, or CMS, recently issued an informational bulletin to the state Medicaid directors. And an informational bulletin is simply guidance to the states. When I go to a state and say, you need to pay for housing, for services and housing better, they say, well, is that something that CMS will approve? Because they have to go to CMS to ask for approval for the things that they're going to pay for. And I've said, yes, they tell us yes, trust me, I promise. Well, now I have proof. I have a letter from CMS that I can take to the states and say, yes, CMS understands the importance of housing support services. They want Medicaid to pay for them, and it's really giving the green light to states to pay for the services piece. That informational bulletin talks about individual transition services. So we're talking about the softer, non-clinical, non-medical supports that for so long insurance hasn't paid for. Individual housing and tenancy support services. And in that letter, they even talk about short-term rental assistance, first and last month's rent, paying for furniture, things like that. And my favorite, and why I get to call Rodney and say, definitely you should do this, is the state-level housing collaboration activities. CMS is saying to Medicaid, we want to pay for you to talk to your housing finance agency, to talk to public housing authorities, to go and find out what the housing need is in the community. And we think you should use your Medicaid reimbursement for administrative costs to do that. This first informational bulletin focuses on those who need long-term services and supports, so people moving out of nursing homes and institutional care. We expect in a few months to have one that's specific for behavioral health and mental health, and call out supportive housing more clearly. So if we can get Medicaid and other insurers to pay better for the services and housing operators and housing authorities can free up some of the dollars that they've been using to pay for services for their tenants, to pay for rental assistance, which helps all of us create more affordable housing. I think that's another piece that corrections and the health system don't understand, is how many flexible housing dollars, how many housers are doing services actually, and the duplication in the system needs to end. And maybe someday we'll be able to convince Medicaid that, you're paying for rental assistance for people in nursing homes, really, when you think about it. Why don't we pay for rental assistance for similar people? Because you're going to see better costs and be able to control their care. So that's why these studies are important, and that's what I want you to take away from today's panel, or what are the messages that we can use when we're trying to advocate for more services and supportive housing. So, as Rodney said, we're going to enter into. I'm going to ask some questions of the panel so that you can get a flavor for for what we found in the study. I'm going to start with Jake. Jake, it is unique, to say the least, for a housing finance agency to invest in a study that measures beyond the housing supports. And particularly outcomes and utilization of other systems. Can you talk about what IHCDA's motivation was for commissioning this study?
Yeah. In 2008, we set a goal of creating 1,400 units of permanent supportive housing. And clearly, we had achieved that goal. It was a great partnership that we have with the Corporation for Supportive Housing and the Indiana Permanent Supportive Housing Institute. If you're not familiar with the Indiana Permanent Supportive Housing Institute, it is a 6-month, basically like a workshop where we identify teams across the state and bring them in to take them through a process of developing the plan for their property, in which they want to undertake and utilize IHCDA resources in terms of capital and rental assistance. Out of that, those 1,400 units was great. I think we were proud that we had accomplished that. And Rodney came into my office in January of 2013 and said, we want to continue this partnership and we want to continue the Indiana Permanent Supportive Housing Institute because look at the number of units that we produced. And for me, it's not always about unit production. It's about what kind of impact are we having on people's lives. And I asked Rodney, show me where we are having that impact. And we weren't able to do that. We knew we could go out to the properties and talk to the properties and they could give us some really good stories, but we didn't have anything to really support what we were doing and the outcomes in how we were changing people positively in their communities. So we agreed then to go, let's look for some opportunities here for us to study the performance of these properties. And Evansville actually was a really good fit for us because it had 4 properties that had been placed in service for about 3 years. One may have been placed in service less than that. And they were serving different types of populations. So they were serving populations with mental health issues. They were serving populations related to our veterans, single parents that had gone through domestic violence. So we had a good sample of individuals there and properties that we could really take an in-depth look at. The properties were different as well. Some of them were single site. One of them was scattered site. And so when you start to look at it from that perspective, it really was a very good, snapshot of the entire state. And so that's when we decided that we were to engage USI. We approached USI and asked them if they'd be interested in this study. They had done a study for Habitat for Humanity, so we knew that they had a little bit of background in housing, but I think they were maybe a little surprised when we asked them about permanent supportive housing. I know that they may not have quite exactly understood what we were talking about, but the more we got into it, I know that the excitement that they had really started to show. And so, but it was a year process. It was, there's a lot of lead time into actually putting together what we wanted to measure, and then actually going through a whole year's worth of surveys and interviews and meeting with the properties. So,
Great, thanks. And so, Mark, can you talk about, from your perspective, why it was important for you to invest in this work and what you've seen out of the supportive housing investment?
Sure. When we were formed in 1993, we were called the Michigan Capital Fund for Housing, and it was a vision that the State Housing Authority, MISHDA, had of creating a state equity fund to basically bring investment into the state that otherwise wasn't coming, to do more difficult kinds of deals. So when I started with the fund, they said, here's the 4 core principles that you have to make investment decisions on. We want to have you invest in distressed communities, try to get nonprofits involved in some form or another, smaller size, neighborhood scale development, 50 units or less, and also serving special needs populations, which at that time in 1993, that was not defined as we all know it today. Just they knew there was something there that needed to be done, but they didn't know how to define it. So that was my marching orders to start the fund and go out and try to raise money to invest. We did 5 developments in that first fund. One of the very first ones we did was a transitional housing development for homeless mothers. It was first new construction for supportive housing in the state that had ever been done. But nobody really had an understanding of the supportive housing model. It came to us, we did it, we didn't understand it. It turned out to be very successful. Next thing, the face of supportive housing isn't just a mental illness issue. The next deals that came to us were domestic violence victims that needed housing. It was people with disabilities. It was then homeless men. It was homeless women. We did a development of women who had AIDS or were HIV positive with their children, that they had nowhere to live. These were all in our early funds. And obviously we became kind of an expert in it, not with a lot of, I sure didn't understand it, but we became experts. The State Housing Authority realized, well, there's something here, and Jim Logue, who was the director of MISHDA at the time, sought out Corporation for Supportive Housing to come to the state and actually put a model on the ground that the state could organize around to actually do this a lot more smartly than we were. And that's really where the supportive housing model really took off, was when CSH came into the state and organized and helped organize targeting resources. When we came to Indiana in the early 2000s, we had formed the Indiana Capital Fund for Housing, and with the same principles. And in 2002, we merged the 2 organizations. That's when we became Great Lakes. That's how you all know us. But it was really Michigan Capital, Indiana Capital, became Great Lakes in 2002. Again, we had a mission to do support special needs housing when we came here, and that was one of the things that state asked us, try to do what you're doing in Michigan here. And right after that, we were able to, bring in CSH into Indiana. We helped fund their operating costs to begin with. Got Sherry Seiwert, who was the executive director then, took this on as a major program for the state, and luckily Jacob has carried it on to kind of its next level. But we have been involved in this space for a long time now. It's been 23 years. We've been the predominant investor in supportive housing in all the states that we're working in. We're in 9 states now. We've probably been the majority investor in all the supportive housing deals that have been done, have a very good understanding of it. And I think it was brilliant that Indiana really led the country with the idea of creating an institute where you really organized all your resources in the state and had people, come and go go through a process that their developments are going to be successful. So, do I get to talk any more after this?
Yes, I'm gonna actually.
All right, then I'll shut up. I've done enough. Okay, I just want to make sure because I got more.
No problem.
Okay.
You're doing a great plug
All
for
right.
CSH too, so I definitely want to have you
Okay.
talk some more. And in the interest of full disclosure, Jim is one of our board members, so that's Jim Loke, who Mark mentioned. So let's get into the meat of the research. So Marie, can you start by outlining some of the parameters of the study and what was looked at?
First of all, is everybody able to hear me?
Yeah.
Okay, I wasn't sure if the mic was on. We had a number of conversations back and forth with the state regarding the variables that were important to assess the cost effectiveness. And what we did as an interdisciplinary team was to develop a number of instruments that would help us understand the full impact of permanent supportive housing on cost effectiveness and quality of life of individuals. And what we came up with was a very detailed case file review instrument and also survey instruments that were used with interviews with individuals who are living in permanent supportive housing.
Great. Thanks. And I should have said, too, that along the way, as you come up with your questions, we are going to have time at the end for Q&A, and that's what the microphone is so write your question down, and we'll get to that once we lay out some of the pieces of the research. So Marie, then can you talk about what the providers and the housing makeup and the case management model that we're talking about when we talk about supportive housing?
Sure. We were interviewing individuals who are living in the on-site supportive housing, such as Visions and Lucas Place 2, which house veterans, and also interviewed individuals who were living in what are called scattered site housing. And individuals who were in the permanent residential sites had the advantage of having at least one or two case managers on site throughout the day. And in the interviews, it became very, very apparent. Individuals praised their case managers, said that they felt they were very, very responsible for them being able to maintain their permanent supportive housing. Individuals in scattered site housing also praised their case managers. What they did share was that they would like to be able to talk with somebody, have somebody there more on a permanent basis. And there was a huge difference between rehospitalization rates, especially for mental health issues, between individuals who lived in the permanent supportive housing sites, the residential and the scattered sites. Also, there was a huge difference in incarceration. Individuals in the permanent supportive housing sites reported almost an 83% drop in going to jail time, whereas individuals in scattered sites, that was not so much the case. However, there was another difference between the two, and that is individuals in the residential sites had lived there most of them had lived there well over a year, whereas scattered sites, we were talking with many individuals who were only there for had only been there for a few months.
Great. So in thinking about that, what are some of the other takeaways that you have for the study?
Actually, we have a number of takeaways for the study. One being a dramatic decrease in domestic violence, individuals experiencing domestic violence. Many of the women that we interviewed indicated that this was the first time that they could live on their own. They didn't have to depend on the person who was abusing them and were no longer with that person. Also, too, a dramatic drop, as I mentioned before, in jail time, being incarcerated. Also, a dramatic increase in individuals keeping their medical appointments, keeping their mental health appointments. Individuals saying that for the first time, they're able to access and take their medication on a regular basis. And many of them said to us that many individuals who also had a substance issue, whether it be drugs or alcohol, indicated to us that their usage had either dropped dramatically or stopped altogether. And when I asked the question, what do you attribute this to? Over and over and over again, they said, because they're able to take their medication, get to their doctor on a regular basis.
Great, thanks. And then can you talk a little bit about some of the limitations of the study just to make sure that we use the information you're providing the right way?
One thing to keep in mind, since this was a study through a university, we had to go through what is called institutional review board. And we could only interview individuals who were willing to sign releases of information that allowed us to interview them. That being said, most of the individuals that we approached to be interviewed did say that they would be interviewed. However, when it came to finding them for the interview, sometimes that was a different story. So what I'm trying to say here is we were not able, for one reason or another, to interview each and every person who were in these different programs. Secondly, this study occurred in Evansville, Indiana. Evansville does have an extensive system in place that helps provide services for people that are experiencing or have experienced homelessness.
Okay, great. So Mark, in thinking about the great results that we saw that we've seen in this study, and trying to increase the investment across the state around supportive housing, how can you talk a little bit about that and how you can use this in the investment side?
Sure. Obviously, people who don't understand these populations and how to manage and operate these developments successfully for 15 years are scared of it. And so anytime that you're armed with data and survey results, it helps us to be able to get investors to invest in funds that have these types of developments as part of the portfolio that they're getting. And that in the early days that was hard because we were told go do this, and we were doing it, and then the investors, when they're looking at it, going, oh, that's too risky. We don't understand it. We don't want you to invest in it. So the more we had real data that shows impact, it helped us to raise money to be able to make the investment. So this is really important to kind of the whole system to have this kind of information.
Great, thanks. And Rodney and Jake, how do you see using this study going forward from IHCDA?
I think having this conversation today is really a great point. The only problem with this conversation today is we're speaking to the choir. Everybody out here understands affordable housing and understands what's taking place with permanent supportive housing. We have to bring in those that are not part of the housing industry and have this conversation with Department of Corrections and the Department of Mental Health. And those that are providing services, those are the ones that should be in this room, and those are the ones that we need to start talking to. Because we do have the data, we have the stories, we have everything that you could ask for to really start to demonstrate the success. But sometimes we continue to talk in the same forum, and we need to break out of that. Because we have to look at housing as just as important as domestic violence. It's just as important as getting the prescription drugs, the healthcare providers. It's all part of the same system. And until we start having those conversations, I'm not sure if we can go to that next level. But I think we have prepared ourselves to do that.
Yeah, from the healthcare side and CSH, one of the things we've started to say is, well, housing is definitely a social determinant of health. Actually, when we're talking about lead paint or is there a grocery store in your neighborhood and those sorts of things, but when we're talking about the housing itself, it more dictates someone's health. It dictates their outcomes, because without it, then you're not going to achieve the other goals of the other systems. Ronnie, did you have anything to add to that?
Later today, actually the Continuum of Care Board meets, and one of the things we're really working on is what we call rebalancing, where we kind of really we mapped our system out and seen all the temporary housing we've had and the tremendous investment we had in temporary housing, and how little investment there is in permanent housing solutions. And so again, data like this really kind of gives us the platform to really talk about rebalancing the system and how we need to move investments from temporary solutions to permanent solutions.
Right. And so along those lines, Marie, let's dive a little deeper into what some of the findings were. So let's start with corrections. What were the findings from the corrections system side?
83% reduction in days in jail.
That's huge.
It is huge. It is very, very huge. And in talking with many of the individuals we had some individuals who had spent a significant number of years in prison. And I spoke with one gentleman who had spent 7-8 years in prison for harming another person. And he said he felt the big difference for him was he is now taking medication. He said, if I wasn't taking medication, number one, I wouldn't be talking to you. I would have probably yelled in your face and run away at the least. And he said, but there's a big difference for me now. I'm able to stop, think, and walk away instead of punching somebody. He said, in the past, I would just act. I wouldn't think.
And also, so the next around substance use, with supportive housing and services being voluntary and using harm reduction strategies, a lot of times there's a misconception that means that people don't engage in services. So one of the interesting pieces of the study I found was the results on substance use. So could you let's talk about that a little?
Yes, we had a number of individuals when we did the case file study before we did the actual face-to-face interviews that indicated a person had a lengthy history of either drug and or alcohol use, oftentimes coupled with jail time here and there for public intoxication misdemeanors. And in talking with individuals, one of the things I would say is in looking through your file, it doesn't give any indication that you've received any substance abuse treatment. And over, I had people say to me, well, since I've been here, I have gone through this program or that program. However, a much higher percentage indicated that just having, I shouldn't say just, a big piece of having their basic needs met, a roof over their head, food, not having to worry what's going to be happening with their children night to night, took a lot of stress off of them. And many indicated that, number one, they didn't feel the need to be using the substances to the extent that they had before. And number two, some individuals indicated that they were using substances to self-medicate because they could not afford their medication. They said it was a lot cheaper to buy a bottle of whatever it was and drink it than to purchase medication. And since permanent supportive housing, being on Medicaid, they're now able to access that medication instead of having to reach for the bottle or whatever other substance.
And then for the healthcare system more broadly with emergency room use and those sorts of things, can you talk about that piece?
Yes, there was over a 60% decrease in the use of emergency room services. And in talking with individuals and the case managers, what I heard over and over and over again was, number one, individuals are now keeping their medical appointments, and whereas in the past, what individuals shared with me over and over and over again was taking care of their physical health. That was at the bottom of their list. They were trying to survive on a day-to-day basis. They were trying to figure out where they were going to sleep for the night, what was going to be happening with their children, and had a few individuals who said that once they came into permanent supportive housing, they actually started accessing services to a greater extent. Now this goes along with other national studies that in the first year that you might see a spike and increase in the use of medical services, and oftentimes that's attributed to people not having taken care of their physical health for a number of years. But as time goes on, what national studies do indicate is a dramatic decrease in the use of those services.
Okay, great. And so then just feeding into that, what do you think are some of the policy implications or things we need to be thinking about given what you found, but taking the limitations into account?
the importance of helping a person take care of their very basic needs. Needs for shelter, feeling of safety. Individuals said that once they were housed, they felt a lot safer. They said, I now have a door, whereas in the past, my door was a blanket over my tent. Also in terms of medical services, emergency room services, decrease in the dollar spent on emergency services. Huge difference. Doctor visit versus emergency room service. Huge difference between person being incarcerated even for a few nights and a month in their unit.
Great, thank you. And so as we transition into the Q&A, so get your questions ready. I want to ask just a wrap-up question. So Mark, just thinking about what you've heard about the policy, about the study findings, can you just talk a little bit more about how that's playing into your work?
Well, I'm going to go in a little different direction because I want to personalize this. I wasn't going to do this, but this seems right now. But this whole issue of permanent supportive housing is a very, very personal one for me in that I have an adult son who was diagnosed with schizophrenia in his early 20s. Had no sign of it before. He was a star athlete, got drafted to play hockey out of high school, came back from that experience, and he was changed. And we watched him spin right down in a hole for 5 or 6 years. Everything you're talking about, he did. He was in jail. He's an alcoholic. He's into drugs. I don't know how many times I had to go down to the emergency room and sit and watch him in a alcoholic frenzy and go through that. As a parent, it's horrible, and you don't know where to turn. And I got hooked up with NAMI, a support group. That was the beginning of something positive. He became homeless, and we couldn't do anything about it. And I was obviously beside myself about it. We really thought he was going to die. I turned, here I am. I'm in this business. I've been doing this housing, and I'm very passionate about it for all those years. And it didn't dawn on me like I really kind of know what to do. But because it's you don't. Right. And so I called a former board member of ours who had been with CSH. I said, I don't know what to do. And she says, yeah, you do. And I said, really don't. She says, well, look at what you've been doing for 20 years. She said, you have a place to go. You're doing all the right things with the support group and all that. And so I started working with my son because nobody else was. It was just him and I. And I was able to get him in to one of our permanent supportive housing developments that we were an investor in. And they had a unit open up, and we got him in. And that was the beginning of the change. He was there. He cleaned up. He's going to AA. He's been sober now for 1.5 years. He got a full-time job. He had all the support services there in that development that he needed, stuff I couldn't provide or anybody else, but it was there. It was a caring face every day, people checking in on him, support peers around him. But he's gone out. He's got a full-time job. He's got benefits now. He's sober. He just bought a house 6 months ago. He's running his first marathon in 3 weeks. He ran a half marathon last year. And it is absolutely directly related to the permanent supportive housing model, is why he's been able to change his life.
Thank you so much for sharing that story. So, Jake, do you have some?
I'm just going to read a quote that we have from the study. And I think that's where I think it's more appropriate to have this. This is one of the single parents that was in one of the units, and she said, I have a place where I can take care of my child.
Great. Well, thanks so much, panel. Great job. So are there questions from the audience? Sure. Do you mind using the mic?
So, hi, I'm Matt Rayburn with IHCDA. You know, Peggy, you had asked the question of what needs to be done next with the study and how we're forming partnerships. And I did just want to acknowledge, because the panel might not know, that we do have in the room with us today Joe Moser, the Director of Medicaid for the state of Indiana. And he has been working with IHCDA over the past few months as a result of the study, trying to find ways that our agencies can collaborate better. So I just wanted to acknowledge Joe for taking the time to come today to continue to learn more about supportive housing and to let the crowd know that we are, in fact, working on those multi-agency partnerships to continue this effort. So thanks for being here, Joe.
All right, Ray.
Good morning. I just would like to make a comment to the Dr. Marie concerning your study, and I have not signed any informed consent, but yet I can state unequivocally that I am a person with a severe mental illness. I was homeless for over 10 years. I am not homeless anymore. I live in permanent supportive housing with a HUD-VASH voucher. I am a honorably discharged United States Marine. I am also a person, as I stated, a person with a severe mental illness, and I have had the honor to be part of the Indiana Supportive Housing Institute. I am also clean and sober for over 8 years. So that study, I stand here to state that that study is real. And to Mark, I think we've talked enough, but not enough, but I mean, there's also that part about NAMI. Man, I can't say enough about it. It's my medication that's not in a bottle. Okay, and yes, I do get that opportunity to take my medication every morning. I feel great taking it. It's better than any whiskey I ever had. Okay, but that's okay. But this is a great thing, and I hope that you guys can just keep it going more and more and more. Oh, and I better add one other part. Just please forgive me about peer support. I am an Indiana Certified Recovery Specialist and a Veterans Administration peer support specialist. I have had the honor to help house some veterans and help them to stay in their house, and also help them along their road to recovery from mental health and substance abuse issues. And please throw your support behind that also. Thank you.
Great. Thank you.
Those who don't know, Ray is he's also on the Continuum of Care Board. And one of the things that the study came out was showing that engagement of those who live in permanent supportive housing are engaged in their community. And there's no better example, not only for the community, but Ray's engaged in the state. He takes time to come to Indianapolis to set through and to be a part and to give us feedback in terms of how we need to continue to change and improve the continuum of care. And it's people like Ray, which I think we should all be inspired to continue to promote and to find ways in which we can do a better job of ending homelessness in our state, because Ray's just is a great asset for our state, and he delivers every day in giving us inspiration and giving us good feedback as to what we need to do to make change. So thank you, Ray, for all the work that you do. So.
Yeah. Yeah, I don't live in Indiana, and I know Ray, so I see Ray everywhere.
My name is Donna Bollinger, and I am honored and privileged to sit on the board of Balance of State Continuum of Care Board with Ray. And you're exactly right. Every month there's inspiration because Ray is there. I had a question. Work with the Performance and Outcome Measurement Committee connected with the Balance of State Board of Directors, and We've had a lot of talk about fidelity tools. We're responsible for next year developing some training with Development Day training, as we call it. And is there something, I mean, obviously the harm reduction principles, sometimes they're easier to understand than they are to consistently apply. There is a lot of controversy about them in our region especially, and I believe wholeheartedly in the Housing First initiative and also harm reduction. We want to help our agencies not only understand it, but know how to do some self-measurement or self-reporting as to how they're implementing this, and maybe a tool. Is there something, we've talked about this, a fidelity tool that we can help our agencies either create for themselves or have something that's standardized that we might be able to encourage agencies to take a look at? I know that we do have one right now that the Veterans Administration has shared with us, that they kind of put a compilation of things together, and I think it's something we can start with. But could you talk about fidelity tools? And I know Dennis Watson also has done perhaps some work on that. I'd just like some discussion on that. Thanks.
Sure, I'll start and then pass it off to, so for CSH, obviously that's important for us. We know that there are places and programs that say that they're supportive housing and that may not meet fidelity and therefore not achieving the outcomes and could then hurt our efforts in other places to create more supportive housing. So we've created a Dimensions of Quality tool that talks about everything from the way that building looks to the services and supports that are attached and how they're delivered on supportive housing. And we're right now piloting efforts for a certification process around that tool. Around the country, and so really soon we should be able to, the dimensions of quality are accessible on our website already, csh.org, but the certification piece is something that we should be rolling out really shortly to help agencies be able to see where they fit within what we call quality supportive housing, and I know that's a big piece of the Institute process. So Rodney or Jake, do you want to talk about that?
Dennis, would you like to? Not to put you on the spot.
So I have to go down here. So there's a lot of...
Take it off, I think. There you go.
So there's been a lot of tools that have been developed by different groups, and I think that the main issue that Donna's bringing up is what is standardized and what is going to be fidelity for that continuum. With the instrument that we developed, we tested it for research purposes, and it seemed to work really well for that. We're having a little bit of trouble getting it to work in terms of actual practice purposes, so we're trying to tweak it and make it more user-friendly. One thing that I think might be helpful is to take it and sort of bring it down to more of a checklist than an actual fidelity measurement tool, so we could talk about that if you want. Something that they have been doing up with the group that I work with in Chicago, if you're talking about sort of holding each other accountable, is that they have developed a group that does fidelity checks on each other, not as a way of not as a way to censor each other or say like you're doing stuff wrong, but as a way of maintaining quality within that group. So they do regular fidelity checks with each other, and that seems to be helpful, but these are agencies that already are very committed to the issues, so it might not work with agencies that are learning and coming along. They might need a little more hand-holding along that.
The reason I asked Dennis to comment, we're very fortunate. Dennis is with the IU Fairbanks School of Public Health, and main area of research is around supportive housing and housing first. We're really lucky to have him in the state.
Any?
Yeah, my name is Gary Hobbs. I'm with BWI. We're a developer. And we've done a few permanent supportive housing projects here recently here in the city of Indianapolis. And my question is if you can elaborate on any research you've done as it relates to NIMBYism. I know we've had some challenges here of trying to find that balance here, trying to put a permanent supportive housing project in certain areas that we come across quite a bit of resistance. But then we've also taken a look at integrated housing that includes permanent supportive housing. And when we were doing that, we found there was very little research in terms of what that unit mix should be, so you can kind of balance the NIMBYism concerns versus having enough individuals there that are homeless or those with mental disabilities intermingling in with other folks who are, with market rate and affordable housing. But we found very little data in terms of really trying to understand what that mix would be. So can you elaborate a little bit more on your research in that area?
Sure. Rodney, do you want to? Okay, so we really find that the NIMBYism question is a lot is community by community. So as far as research, I think one of in the study itself, there's a good bit on community. On what the housing has done for the community. Marie, do you want to talk about that?
Sure. What I can tell you is that in Evansville, Visions, which is an on-site permanent supportive housing, it's residential, was created in an old industrial area of Evansville, in an area in which having this there has seemed to bring the neighborhood up. Another site in Evansville was created in an area in which there were several abandoned homes. Regarding the scattered site, Evansville has agencies have worked very hard with landlords in Evansville to accept individuals who had formerly been homeless. There are a number, in talking with the case managers, there are a number of landlords that are on board and do recognize that with supportive services, these individuals make very, very good tenants. So what I'm trying to say here, it's building the reputation. I don't think it happened overnight, but it happened over a period of time where case managers culled these relationships, agencies culled these relationships in order to make this happen.
Yeah, and I think the other place, so that's another piece where this study is so helpful for Indiana, is to be able to show an Indiana-specific study that shows the improved community that supportive housing has helped create. The other place that we focus on a lot is in Philadelphia. Project Home there has done a significant amount of work around developments locally and how that's been able to bring back neighborhoods, not bring down neighborhoods. But as I said, I think the NIMBY conversation is very local. And so what we've done to combat that is really do a lot of peer and bring people from communities like Evansville, where it's really successful, to go talk to the other community where you want to create more supportive housing. Because people, just the same as, if I go talk to a legislator, I'm in DC, and I go to talk to the Colorado legislature, they're not going to believe me about what's happening in Colorado. In this instance, it's about, similar neighborhoods and similar communities talking to each other to be able to trust that supportive housing actually is a community benefit and not a community detriment.
I think we've also kind of are in a transition period where, for the last 7 years, 8 years, we've been really gearing up and getting production up. And again, we're at kind of a transition period where I think the supportive housing movement is maturing here in Indiana, and that really kind of highlights the need of future studies as units have come online to look at the community impact. I know there's a study in New York about property values around supportive housing, how they've gone up, and kind of replicate that study here in Indiana and look at some of those issues.
Yeah, I know, at least from personal experience, going to the Bronx 12 years ago and looking at supportive housing, and going to the Bronx now and looking at where that supportive housing is, there's definitely been a lot of community development around places that before it wasn't happening. Oh, yeah, okay. I thought we had till 10, so no problem. All right. Well, I want to thank the panel again. Thank you very much. Thanks to all of you for your great questions, and look forward to the rest of the conference. Thanks.